critics worry that even though, as you say, this will be covered by your OHIP card, critics point out that these for-profit clinics often try and upsell patients. You can have your cataract lens paid for by the government, or you could have maybe a better one for a fee. How are you going to protect against this upselling, Premier?
Well, thanks for the question, Richard. Our main goal is to reduce the backlog surgeries. We're in excess of over 206,000, even pre-pandemic. If we get to the pre-pandemic levels, that's just not acceptable. We need to do things differently, come up with new ideas, working with hospitals and CEOs, partnering with the CEOs of the hospitals and some of the best experts. When I read an article, and someone told me this prior, and then I read it in an article, that surgeons are actually performing surgeries only 1.5 days out of the entire work week. And they have so much more capacity. I've talked to so many surgeons that, tell me they have more capacity, but they need the operating rooms to be able to do the surgery. So this is one step of making sure we provide care, no matter if it's cataracts, hip replacements, knee replacements, foot surgeries, diagnostics, and it takes the burden off the hospitals, that the hospitals will do the critical surgeries.
Premier, what happens to this plan when the wait times in hospitals return to more manageable levels? Are you still going to add private care? Is this just temporary or is this permanent, sir?
No, this would be permanent. Reason being, we have an aging population, the baby boomers, old guys like myself eventually get up there and we need more care. And we have newcomers coming into Ontario to a tune of about 300,000 a year for the next 10 years. So we're going to be creative and take the best ideas from around the world, from around our own country. Look at BC, look at Alberta, look at Quebec. They're delivering it a little differently, and they're being successful. But thanks for that question.
Morning, Premier. Liam Casey with the Canadian Press.
Hi.
Wondering where the staffing is going to come from for these new surgical centers. How are you going to ensure that the hospital systems aren't pillaged?
I'll pass that over to the minister.
To after?
Sure.
Thank you.
So we're doing it in a couple of ways. Of course, we have greatly expanded the ability for internationally educated nurses and other healthcare providers to practice in the province of Ontario. Now, in fact, if you have practiced in other jurisdictions across Canada, you can seamlessly practice here. So we've done that. We're working with Minister Dunlop to make sure that we have more opportunities for individuals who are interested in training and being a healthcare practitioner, which is very exciting, like the Learn and Stay program. So we're doing a lot of different pieces to make sure that we have sufficient health human resources across our entire sector, but we're also doing it in a short, medium, and long-term way so that we have more people interested in being trained, but we also have worked with the College of Nurses and the CPSO to make sure that individuals who are waiting to practice in Ontario get their qualifications assessed quickly and ultimately, when appropriate, licensed. So those short and longer term goals mean that we are very much seized on making sure that as Ontario's population increases, we have appropriate staff ready and willing to work in the sector. Thank you.
Yeah, thanks for that, Minister. So I always believe it's not either or, it's and. So we have great hospitals working hand in hand with the clinics, and that's the way we're going to operate. Excuse the pun, but that's the way we're going to move forward with this. We have the best doctors, in my opinion, in the entire world. I'll put our docs up against anyone, best surgeons. And when they have more capacity, and they're telling me they have more capacity, but they need operating room time, then that's how we're going to deal with it. But at the end of the day, what we want to do, the bottom line, is reduce the backlog when it comes to the wait times, and it affects people's lives. So many people. I remember my mother, before she passed away, she had her hip replacement, and there was a real decline, waiting, and people that need a knee replacement, it affects their life. So we can't just leave them on the bench there for a year to wait. We have to make sure that we provide the surgeries that will change their lives and be able to be mobile again. And same with cataracts. And the folks at Kensington, they're just experts. And again, I want to thank Terry and his whole team. You want to talk about the gold standard? We're here at the gold standard right now at Kensington, and there's other clinics, as you know, that have been doing this. There's other provinces have been doing it for years, so we need to follow suit.
Thanks. Surgeons are telling me that there's a lot of operating time available within the current hospital system, usually evenings and weekends. Why not take all this money that you're investing in this program, and why not put it into the hospital system?
Well, again, I don't think it's either or. We're investing another $300 million. I've never directed the hospitals. I never will direct the CEOs of the hospitals. I think they do a fine job. They know their budgets, but this will add additional capacity. If we all know, if we just leave the status quo and just leave it the way it is, you'll be talking to me next year and we'll still be at 206,000 backlog surgeries. We want to help the people out there that need a hip replacement, knee replacement. It will change their lives. They'll be able to be mobile again. And not just that, foot surgeries too, cataracts, MRIs. How many times have you heard your friends, family members going into a hospital, an MRI at 2 o'clock in the morning, at 3 o'clock in the morning? Because that's the capacity they have. And by the way, we have approximately about 900 of them across the province is being done now. We just want to expand on the existing 900 that provide the care.
Hi there, Alan Hale from Queen's Park today.
Hi, Alan.
Critics and including the College of Physicians are very worried that this kind of move will inevitably draw more people from public hospitals into these private clinics because there'll be more money and things like that around. Now, we've heard that there's going to be some kind of safeguards to prevent a mass migration from public hospitals to these clinics.
Yeah.
Can you please give us concrete examples of how you are going to prevent that from happening?
I'll pass that over to Minister of Health. Thank you.
So I want to start by reinforcing that the vast majority of new nurses that were licensed in the previous year, in fact, ended up being hired and working within our hospital system. It is by far the number one employer of our healthcare nurses. So what we are doing in the application process, part of the application process for new community and surgical units is to say, what are your plans for your health human resources? How are you planning to staff up? Is it existing staff that you are working, they are working longer hours, or do you have a plan in place? And it will very precisely talk about the need to protect our public hospitals and ensure that they are not in any way impacted. They're going to be assisted because those regular lower risk surgeries are happening here in community and happening quicker. And I really want to reinforce that this really is about quality of life and quality of life for those patients who've been waiting too long for some of these routine surgeries. Thank you.
It seems like there's a bit of a lack of enforcement going on. We didn't hear an answer about how you will stop upselling, and it sounds like you're leaving it entirely up to the clinics to decide on how they will somehow not draw much needed staff from hospitals. Do you put that much stock into like a report? I thought as a way to get things done.
I put a lot of stock into great, clinics like Kensington. Look at the backlog. Imagine if we got rid of all the clinics. Imagine if we got rid of all the independent health clinics, all 900. You think waking up at 2 o'clock in the morning would be bad? We wouldn't be able to keep up. This is going to be safe. It's going to be regulated. You're going to have the exact same doctors that are operating in the hospital operating here. We're going to let the serious operations happen at the hospital. But you know how you can change someone's life? You know how many people are listening to me right now that are waiting to get an MRI, CT scan? How many people are, don't have the quality of life because they're sitting at home needing a hip replacement or a knee replacement or a foot surgery? We're going to change people's lives. We're going to make sure we get caught up. But being on a wait list of 206,000 people, pouring money, an unprecedented amount of money. I'll just give you an example into the healthcare system. We'll continue doing it. But we've added $14 billion since 2018. We're building new universities. We're building 50 new additions and new hospitals across the province. We've added 3,500 beds, adding another 3,000 beds. We've hired over 60,000 new nurses that have come into the system. Again, close to 8,000 doctors. So, we'll continue pouring resources, some financial resources. But let me tell you, every healthcare professional, every doctor, every CEO I talk to, they tell me, Doug, it has to be different. We have to come up with a different methodology. We have to come up with a different process. Because if we keep doing it, we're going to see the same results. One CEO, and I won't name him, said, you know what there's only two places in the world that have the healthcare that we have, the same system, is Cuba and North Korea. Like, really? We need to improve. So we're making the changes with the support of the CEOs and with the associations, and we're going to get it done. We're going to chip away at this, and we're going to do it safely. We're going to do it cautiously. We're going to do it slowly, and make sure that everyone's informed.
Hi, Premier. Hi, Minister. Christina Tenalia from CV24.
Hi, Christina. I haven't seen you in a long time.
Yes, nice to see you.
Yeah.
You've been very clear that these procedures will be covered by your OHIP card, not
That's
your
right.
credit card. What about, and can you say confidently to the people of Ontario that they will not have to pay for, let's say, staying at one of these facilities, and that the only out-of-pocket costs would be what you could expect to pay at a hospital, say parking and maybe some medications? What are the additional out-of-pocket costs that Ontarians could expect through these procedures?
Well, outside of the parking, good point. Yeah, they'll be paying for their parking, but no one is going to be paying any additional cost. They'll never use their credit card. They'll always use their OHIP card. And we're going to continue doing that. Do you know who runs independent businesses? Are your primary care docs. You go into your doctor, that's his own business. He pays for the overhead. You never get a bill, but OHIP pays the doc, and that's how we're going to run it. That's how I can explain it. So that's the only cost they're going to be seeing.
Okay, thank you, Premier. This question for the Minister of Health. What is the breakdown of these community-based clinics like the one we're at today that's not for profit versus private health clinics where these procedures would take place, and why? Is that just based on space and availability?
So it's actually been an application-based system where individuals, organizations, in some cases like Kensington, not-for-profit, and others, profit centers, apply. And then we in the ministry make an assessment on whether the need is in that community, and ultimately those applications are approved. And I might add, are approved and ultimately assessed every 2 to 5 years to make sure that the service that they committed to is needed and still happening in communities. So there is a lot of oversight that happens to ensure that where we are citing these locations are appropriate for community need. And as the Premier mentioned, there's over 800 currently in the province of Ontario, surgical and primarily diagnostic. But that's why we need to see, we've seen that system work in whether it is for-profit or not-for-profit, and it is an application-based process. Hope that helps.
Thanks. Hi, Jeff Gray, Globe and Mail. That ties into my question, which was, my understanding is there'll be sort of an RFP, an application process, when you go to expand to hips and knees and you actually are going to have new clinics set up, not just existing clinics. Do you have, can you give us some indication of how many clinics, how many new licenses, and how many surgeries we're talking about when we get to that phase?
I think I better hand it back to the minister.
So I can't give you a hard number. What I can tell you is appropriately it is application-based, and what we will see is Ontario Health being able to make assessments and work with the community. So what is available within the hospital system, what is available within the current community-based diagnostic and surgery system, and where are the parts of the province that need additional capacity. And that's how those assessments will be made. And it will, as I mentioned previously, also have a Health Human Resources component that says, tell us, share with us how you are doing this. But what we have been missing is the piece to have coordination between where those centralized wait lists that happen for surgeries. Now we can say, here is the appropriate place because it is a routine surgery, here is the appropriate place because it is a high risk, and here's the capacity. And Ontario Health will be a very important partner, as of course the Ontario Hospital Association.
I'm just noticing the two operating chairs behind the two politicians. I don't know if there's a photo op planned later. We might want to be here for that, involving a laser or something.
They can laser half my stomach away. That's what I'd like to see.
And I wanted to ask this as a follow-up just about that. When we're implementing this, the safety piece, the inspections piece, there was a previous round of trying to add to the number of IHFs years ago under the Liberals, and it stopped in its tracks when somebody coincidentally had died in a plastic surgery outfit, I believe. It's going back a number of years now. The College of Physicians and Surgeons did raise some concerns last week about this whole process. How can you assure us that these places will be inspected, will be kept safe the same way our hospitals are?
Well, I was shocked. Number one, the college would even respond. What they're doing is putting in question their own ability to monitor this. They're doing it right now. So are they questioning their capacity or their qualifications? I hope not, because they're doing it right now. And I was actually shocked to hear they would come out and say that. They're questioning their own credibility. I have confidence in them. I have confidence in the processes. I have confidence in the regulations and the doctors that are going to be performing these surgeries. So maybe you should ask them if they have confidence in being able to handle this or not, because they're doing it right now.
Hey, Premier and Minister. I'm Charlie Pinkerton of Queen's Park Briefing. Premier, you've said today that these changes are going to be permanent, and you've also emphasized a few times the need to borrow from other jurisdictions that are having success with similar issues. I'm wondering, what is the line in terms of other surgeries or procedures that in the future your government might entertain having done at the same kind of facilities that we're speaking about today?
Thanks for that, Charlie. Before I pass it over, let's just step before we run. Let's walk before we run, I should say. Let's get the cataract surgeries, get the backlog there. Let's change people's lives and take care of the hip and knee replacements, foot surgeries. Which you add them all up, what I understand is 50% of the surgeries. That will allow additional capacity at the hospitals to do the serious surgeries, the life-saving surgeries. So I'm not too sure if the minister wants to comment on that.
Just to reinforce what's the driver? Quality, 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 right? Quality of life for that individual who's been waiting for the hip or knee or cataract surgery. Quality that you will see and deserve and know is happening right now in our community surgical and diagnostic centers, because they are all trained, they are all under the same controls and oversight that exists whether you operate in community or in hospital. What we want to do is make sure that people's quality of life improves with the changes that we are making. And that happens when you don't have to wait months and months for a surgery. It happens when a routine surgery that is scheduled in your community hospital has to be canceled because there is an emergency that is coming in. So we're going to make sure that it is all driven by quality of both what the patient deserves and expects and what they will get from very talented and exceptionally trained practitioners in our province.
Okay, and so just to clarify on that point, do I follow that other surgeries, procedures could move into these types of facilities later on if this plan is something that shows success? And then on a similar note, With this being application-based, are you encouraging as many facilities like these as possible to apply? Do you want as many as there can be?
I want organizations that believe that they can provide more service in their community, expanded service in their community, to absolutely apply. And as the Premier mentioned, we are going to start with the routine surgeries that we already have in existence in the province of Ontario and expand on that. And as we see that success roll out and capacity being needed, then we will look at expanding further. Thanks.
Mike Crawley from CBC News. Premier, do you understand why a lot of people are concerned about the idea of for-profit clinics doing surgeries? I understand your point that doctors' offices are run as little for-profit corporations, but if you actually have private sector investment in creating these surgical clinics doing operations, they've got to make a profit. And so do you understand why people are concerned about public healthcare dollars going to for-profit corporations?
Well, Mike, something, we're doing it right now. It's happening across the province already. All we're doing is expanding on it. And it's the ideology. Some people just, let's leave it alone. Let's just keep doing the same old thing and expect a different result. Well, that doesn't work. So we're going to continue moving forward and changing people's lives, giving them the opportunity to be able to get up and enjoy life, rather than a chronic, hip pain or a knee pain, or you can't walk on your foot, or in the case of cataracts, are waiting, forever for an MRI. It's unacceptable. There's different methodologies of delivering the services, and we have consulted with everyone and their cousin and their brother and their doctors and CEOs and you name it. And this is the best way to go to take the burden off the backs of the hospitals and right across the board. So we'll keep doing it cautiously, but we already have it. We're expanding the system that we have already.
And Premier, can you explain how moving these, I think as you called them, uncomplicated surgeries, or as you said last week, no-brainers, moving these surgeries out of the hospital system into these clinics, how does that actually help the rest of the health system, things like the overcrowded emergency rooms?
Yeah, so it actually helps them tremendously. Mike, the way I can describe it, you have a dam, you have a log jam. Are you going to just keep pouring the water up against the logs, or are you going to reroute some of the water and take the pressure off the dam? You see what happens when the dam has too much water, it breaks. So we're rerouting the simple surgery. I guess no surgery simple, but the easier surgeries that are taking up 50% of the capacity at the hospitals and causing people to wait for the serious surgeries as well. We want to make sure that we take care of the people that have life-threatening surgeries that need to get in there, life and death. So we want to make sure they get in there. And the way we do it, we take the burden off the system by rerouting the patients into basically another facility. Same doctors, same regulations, same quality of care, and excellent service. Actually, I think people see even better service. That will allow our hospitals to provide the excellent service that they want to provide to the people.
Hi, Premier. Rob Ferguson from the Star. I didn't hear a really clear answer on this before, so I'm going to try again. On the so-called possibilities of upselling. So, will that be allowed or not? For example, if you're getting new cataracts, could a clinic say these are the OHIP funded lenses that we will implant, or you could have the next grade up, kind of like going from a Chevy to a Cadillac, that kind of thing. Is that kind of thing going to be allowed?
I will pass it over to the minister.
So I think it's really important for people to understand that OHIP covered services will continue to be. And if there are examples where someone was not given the option of the OHIP funded and only given the upgraded model, then they have the ability right now in the province of Ontario to ask for an investigation through the Ministry of Health. And we do those regularly in the province of Ontario. If there is a concern, people bring that forward. We do an investigation, and when appropriate, we will ultimately refund the individual or the patient who received something that should have been paid for by OHIP. I want to reinforce that the publicly funded system is such a critically important part of what our Ontario health system is, but we also need to see how other jurisdictions have been doing it successfully. And the Premier talked about, Saskatchewan, Alberta. Alberta has over 20+% where they are doing surgeries outside of the traditional hospital model. It means faster service, faster access to service. And it means that those individuals who've been waiting can get back to their families and communities in a faster way and actually be part of our communities. It really is about making sure that people who are waiting have an opportunity to get those surgeries or diagnostics faster.
Okay, I'm still not clear. You said that if something improper has happened, you can ask for an investigation.
As it exists right now.
But is it going to be okay to say to someone, you could have a better lens if you want, or you could have a better joint if you want?
So, I'm going to reinforce. OHIP-funded services will continue to be covered in our community surgery and diagnostic centres. And if and when there is an opportunity where someone was not, sorry to interrupt, was not told that the OHIP-funded service was X, there is currently in the province of Ontario and the Ministry of Health a investigative branch, and ultimately funds are returned if it is appropriate.
So that's a yes. The upselling is allowed then.
This will be the last question. This question, sorry, it's Siobhan from CTV. This question might be better for Minister Jones then. Aren't you putting a lot of responsibility on people then, who do not know the ins and outs of the healthcare system as you do, to know what is covered, what they should be offered, and have to go to the length of an investigation? Just seems like a lot of extra steps.
Well, I think it's important as we go through the pathway of ultimately having a conversation with your primary care doc, getting an assessment through the diagnostic system, ultimately, if appropriate, having surgery. Your family physician, your family clinician is part of that process all the way through. And they are truly the clinical experts to know what is appropriate and what is available in the province of Ontario. Thank you.
And what's the pay structure for, I don't know if it's different from clinic to clinic, for doctors, surgeons, nurses, in terms of what they be paid per procedure or for a day's work? Is it different than the hospital system?
So, challenging question to answer because there are a number of different fee structures depending on if that physician is a hospitalist, if they're there for certain surgeries on call. So there would be many, many different types of fee structures depending on how much time they are at that particular hospital or that particular clinic.